The degenerative de novo scoliosis, it refers to the scoliotic curves developing after skeletal maturity. I want to forward this. I hope I have control, but it's not popping up on my screen. So let's see. Okay.
You have control.
I do. I'm looking for the floater that comes on. So let's try this again. Okay. There we go.
At the bottom left.
It worked on a test, but it's not working now. So anyway, so the scoliotic curve, as we know, there we go. As we know, is measured from the AP view. And we all know that that's the line drawn from the upper end plate of the upper body, and perpendicular lines drawn to the first two lines as measured. So there's degenerative spondylolisthesis that is associated with common degenerative scoli, and as we know, the lumbar stenosis also is frequently associated with degenerative spondy, and there is a prevalence of 4 to 15%, which increases with age. The mean age of patient with degenerative scoliosis is about 60. So with the clinical presentation, lumbar scoliosis with degenerative changes are prominent. The scoliotic apex can produce stenosis resulting in low back pain, radicular symptoms, neurogenic claudication. So we've talked about multiple classifications for scoliosis. Typically one that I use these days with my fellows include the Schwab et al. Classification I've shown here. And really, when we start about complication management, I want everybody to be familiar with some of the rudimentary assessments, plain full view, standing AP lateral, measurements made in the sagittal and coronal plane. And we want to also assess the degree of spinal stenosis, spondylolisthesis, and all the associated spinal degenerative problems. Obviously, a lot of people show up to you with having tried non-operative treatment, but it's essential that you actually assess those that you immediately need to take to surgery versus those that will benefit from some non-operative treatment. It's also something that you have to do for most of the payers out there. So one of the operative treatment, the main aim is to decompress neural elements and also end up with a balanced and stable spine in the coronal sagittal plane. And in these days, we're also wondering about the 3D whole spine. Okay. Seems like you have to wait till, there we go. So indications for surgery include for patients over 50, you want to document some curve progression or decrement in their back and radicular symptoms. So in terms of complications, I'm going to just hop on in a few. This is not all that you can end up with, but as the course goes on, there'll be more examples to show. So the older patients have an increased risk of surgical complications. Operative neurologic cardiopulmonary wound infections, and also implant failures. So this is a paper that I found very useful from the ISSG, which looked at 346 patients, 270 perioperative complications in 152 cases. Complications were associated with older age, BMI, increased comorbidities, previous spine fusion, and also 3-column osteotomies. And when you look at that, you could just see the incidence of neurologic, operative, and cardiopulmonary, as well as wound infections. So if you look at neurological deficits, this was a paper that came out with the Scoliosis Research Society about a decade ago, looking at over 108 procedures. And things that we looked at and noted were that there's at least a 1% overall neurological deficit, rate dependent on the complexity of the surgery, as seen in the ISSG data also. And the higher rates were associated with long construct fusions, implants. However, it's reassuring to say that about 91% achieved partial or complete recovery, and this was decreased with those who actually had spinal cord injury. And you can see from this table that there's nerve root injuries have a higher complete versus partial improvement versus the spinal cord injury patients. With infections, it's about 1 to 5%. If you're out of that range, you should really critically look at your incidence, your hospital practice, and it's increased with length of surgery, age, patients' other comorbidities, and also your intraoperative complications. As Dr. Chapman said, duodenectomy it could upset things and it's not benign. This is one of my own personal concerns. This is a patient who was discharged to a nursing home and presented at the 6-week follow-up with a back like this. And it's sort of hard to stomach where patients go, but if they come from a rural area or even in an inner city, benign neglect in a nursing home, you can show up like this even with your best intention of massive wound adhesions with estrade showing. This requires a large irrigation, debridement, etc. And you have to have your plastics colleagues be involved, or with aggressive wound management. You may end up with this is a patient that presented while I was on call on behalf of one of my colleagues. And sometimes you can just see pus just pouring out of a wound that has been festering for a while. You may end up having to wound vac the wound for it to clear. And sometimes you have implant failures. And in the best occurrence, I normally will have a sort of a diagonal, or shall I say a rotating AP view, because if you look at it head on, you may not see it. So I have them do a sort of a diagonal, I call it the Hamilton diagonal view or rotating view, to actually see where the implant fractures are. So you don't get surprises, or you don't do a unilateral takedown and then miss the other side that's also fractured. And you may have to contend with eventually removing your implants, as in this patient who presented on 2015, underwent surgery by 2019. They had fractured so many, and this could be a result of the level of correction that we achieved versus pseudoarthrosis. But eventually, she sort of had bone fusion. We removed the implants. She's the happiest ever, and sometimes I surprise myself with that. But this is in order to stay on time. I want to give a bird's eye view. To say that complications in scoliosis surgery or care, despite your fastidious precautions that are required, and you need a whole team to minimize this. Your anesthesia, your hospitalist for preoperative check-in, postoperative check-in, your own interest, and also rounding, making sure that the things that will bite you, tubes, Foley catheters, etc., lines are removed expeditiously. And also your patient is pre and postoperatively well nourished. And to expedite some cases, you may need a co-surgeon to help with things. Thank you. Any questions at all?
Kojo, that was great. We're going to see if there's any questions from the audience. So one question I have real quick, Kojo, is do you use neuromonitoring for cases? If, let's say, if you have a change, do you have a protocol that you follow?
Absolutely. The only cases that I don't use neuromonitoring currently are cases that involve decompression in the lumbar spine. In thoracic or cervical decompression, I do use neuromonitoring. And it's a very unique. I'm very high tuned to what's going on with the anesthesia field. If there is any note of a change in any of the signals, I use multimodality SSEPs, EMGs, motors frequently. I want to make sure that the patient's blood pressure is not low. That seems to correlate really highly, particularly at the onset of decompression. There's any vascular ischemia or any spasming of the vessels with decompression, that they are well perfused, and also that we're not going on with a below hematocrit if there's any bleeding lung fusion. So increase in the blood pressure is essential. And also I take about steps back about 15 minutes prior. What did we do? Did we do an aggressive correction, or did anything happen? Obviously, if there's an iatrogenic event that's very visible, I want them to quickly drive the pressure up, and I've given them, pre-dose steroids. If I'm doing long fusions, I think I tend to have that, and that's just my own practice.
Great. Thanks, Kojo. And then there's a quick question about TXA, and then there's also there's a question about how many of these cases, what's a minimum number of cases of scoliosis cases that somebody should do a year? In other words, should you do like 1 a year, 20 a year? Is there a magic number?
There's no magic number, but I do believe that doing at least 40 a year of actual scoliosis is important. Not curves greater than at least 25 degrees, and really it's essential that you have dedicated fellowship time. Or if you're if you're graduating from a program that has a lot of scoliosis mentors, that's essential. That you can, your own personal idea should be, before I graduate, I should have at least 200 cases of long construct scoliosis, either via MIS or open deformity. I think that's well achievable before you start. But even if that's the lowest conservative end.